I teach a lot, and once I was asked to teach a class on ABG interpretation and end-tidal capnography. When the lead instructor heard about that, she said, "Bill can't teach that. Bill doesn't believe in capnography," which is kind of a funny point of view, but it's not necessarily true either. I understand what capnography is, how it works. I believe it. I know it exists. So I understand how it works. I understand how to interpret it, and I understand how I use it. I do think that there's experts that oversell what it can be do, overinterpret what it can tell you, and overpromise what it can do for your patients. I'm going to talk about an article from EMS1 recently by a guy named John Eric. It's actually a pretty good article, but I think it illustrates that kind of overpromise that you can run into. Tell me in the comments. Let me know if I'm just an old guy who can't adjust to new technology, or if what I'm talking about is reasonable. Stick with me, it'll be a really good one. So I'm Angry Bill, this is pre-hospital wisdom. We understand that medicine's medicine, but pre-hospital providers like paramedics and EMTs have special skills and knowledge and culture that make us a little bit different. Let's raise the bar here a little bit. Many writers and other experts, we'll call them capno gurus, oversell what end-tidal CO2 can do. They oversell how it can help your patients, overpromise on what it can tell you, and underdeliver on how it should be interpreted. It seems that some people see capnography waveform as useful as a 12-lead EKG. I don't believe it's quite to that level. So let me see if I can convince you here. For example, have you ever been told to watch the end-tidal CO2 during an arrest? Stop CPR when the end-tidal jumps up. Ignore whether or not the patient has the number changed. The number on the monitor changed. The clinical presentation of the patient is unaffected. Treat the monitor and stop CPR. So yes, I understand the science behind that concept. I understand the science behind that thought, but I also have severe difficulty at stopping CPR when there's no pulse. Another example is Capnography, King of the ABCs by Troy Valente. It's called King of the ABCs after all. I mean, that's a lot to promise. I got to actually admit, it's a pretty good book. I own 2 copies. One's all handwritten in and screwed up. The other one's the one that I use. If you have a chance to read it, make sure and do it. The final point is this EMS1 article by John Eric called The Beauty of the Orange Line, How Capnography Can Change a Diagnosis. This article is a report on a webinar by Chris Kroboth of Lifeline EMS in Virginia and Dr. Jeff Goodlow of Oklahoma, I believe of Oklahoma City and Tulsa EMS. The article argues that capnography, end-tidal CO2 monitoring, should be used routinely in EMS patient assessment because it provides real-time insight into ventilation, metabolism, and perfusion, 3 critical physiologic systems. Because of this, many clinicians consider it one of the most valuable vital signs in pre-hospital medicine. That's the point that I want to talk about. The article reviews several clinical cases in which capnography revealed important clues that traditional vital signs would have missed. Example number 1 is a minor car crash involving an elderly patient. Normal vital signs suggest the patient's stable. She has a heart rate of 74, blood pressure 124, radiant is set in 99%. Do you notice the vital sign that they left off? The author states that normal vitals suggested that the patient was stable, but a low end-tidal CO2, 32. I don't think it's all that low. With the elevated respiratory rate of 22 suggested hidden injuries such as pulmonary contusion or pneumothorax, prompting further evaluation. Count the respiratory rate. An elderly patient involved in trauma with a respiratory rate of 22 after a period of calming and relaxing, your index of suspicion should be higher. I don't need capnography to tell me that that patient is one I should be concerned about. Example 2 is an elderly patient presenting with weakness. 78-year-old woman, generalized weakness and altered mental status. Altered mental status is always the bigger concern compared to generalized weakness, but she was cool to the touch, slouched in a chair, staring into space. She's got a heart rate of 85, blood pressure 120 over 77 and 97%. Her respiratory rate is 24. That's all I need. This is a sick patient, likely septic, but I need to run through all of the other causes of elderly altered mentation. The end-tidal CO2 of 31 is not especially low as that, not especially outside of all those bounds. I'll explain why in just a second. The third case presented a female who's 32 years old, weak and nauseated. She's also pregnant. She is visibly pregnant. The author states that low end-tidal CO2 with tachypnea suggested a metabolic issue, prompting a glucose check that revealed severe hyperglycemia. This is a tachypnic pregnant patient that's weak and nauseated. Blood sugar check is obviously indicating the blood sugar check finds hyperglycemia. This is gestational diabetes, maybe even resulting in diabetic ketoacidosis. Again, I don't need the end-tidal CO2 to tell me that this is a patient that I should be concerned about. Case 4 is a young trauma patient with clavicular pain. A man in his 20s fell on some steps and complains of clavicle pain, speaking in short, terse sentences. His heart rate is 109, he said, in 98%. His blood pressure is 132/83. He is pale and cool, but the author says he's not overtly unstable. He's tachycardic, pale, and cool after trauma. The end-tidal CO2 was slightly elevated, and the respiratory rate was 22. While he was breathing fast, he wasn't ventilating well. He then became even more short of breath and changed to one-word sentences. This is a pneumothorax with clavicular pain and everything. I don't understand what the author is trying to illustrate that end-tidal CO2 is solving for me here. I think all of these cases, by doing a complete physical exam, taking a good history, doing a complete set of vital signs, and having a high index of suspicion, like with your paramedic brain, answers all of these questions. I'm unconvinced that the end-tidal CO2, that the capnography is the end-all be-all many experts think it is. Now let me take a second and explain how capnography works, what it's measuring, how it works, and how to interpret it. In order to do that, we're going to start with some vocabulary terms. All of this starts with the last one, is respiration. In this case, we're not talking about a respiratory rate, which is the air moving in and out. That's actually a ventilation rate. What we're talking about is cellular respiration. The production of energy using oxygen results in water and carbon dioxide. Carbon dioxide builds up within the cells and needs to be moved and released somewhere. So what we think of respiration isn't actually respiration. What we think of as respiration is actually ventilation. Ventilation is the movement of gases, usually room air, in and out of the lung. Diffusion is the exchange of those gases between the alveoli and the pulmonary blood. Usually we think about this as a lung full of oxygen diffusing across the capillary basement membranes and such onto capillary blood, attaching to hemoglobin, be carried further to body tissues. But also, carbon dioxide that was produced by the cells during cellular respiration diffuses into the blood and diffuses out during this process into gaseous form in the alveoli to then be exhaled. Perfusion is the circulation of blood to tissues that delivers oxygen, accomplishing oxygenation, the process of ensuring adequate delivery of oxygen to the tissues, but also perfusion also removes waste products such as CO2. Cellular respiration, the act of being alive, causes carbon dioxide to be produced. That carbon dioxide moves into the blood, where it moves through the either inferior superior vena cava, into the right atria, the right ventricle, and then into the pulmonary circulation, where it diffuses off of the blood into the air within the alveoli. That air is then exhaled, and capnography is measuring the amount of carbon dioxide in that exhaled air. In one way of thinking about it, capnography is showing a lot of metabolic processes, a lot of life processes. You just have to be careful not to overinterpret it. A couple of more terms. Capnography is the waveform, showing a graph over time, measuring the amount of carbon dioxide in exhaled gases in millimeters of mercury on the vertical axis and time on the horizontal axis. Capnometry is the measurement of a value, the production of a numeric value in millimeters of mercury. Normal value is thought to be between 35 and 45 millimeters of mercury for end-tidal CO2. I don't actually believe that. Sorry. See if I can convince you in just a second. We'll talk about it. Colorimetric monitoring uses pH paper to measure exhaled carbon dioxide, and the paper turns yellow and purple depending on whether it's being exhaled or not. This is a quick Confirmation still used in many locations to monitor the placement of an endotracheal tube. You can see some examples on this slide here. Oximetry is the measurement of the percentage of bound hemoglobin. Usually modern probes can tell the molecule bound to hemoglobin. They're often termed as rainbow. If your monitor also tells you the SPCO in the same box where you can dial over where the SpO2 number is and dial in, click it and change what it's viewing. It has the ability through different wavelengths of light to tell the difference between oxygen bound hemoglobin and hemoglobin that's bound to carbon monoxide. And then finally, a pleth. I'm not even going to try and say that word. A pleth is the continuous pulsatile monitoring of oximetry readings, also resulting in a graph. So most modern capnography measures exhaled air via side stream. Colorimetric has kind of fallen out of favor. A photodetector measures the amount of infrared light absorbed by the gas, and the CO2 absorbs specific wavelengths of that IR light. Light absorption increases with concentration, and so the concentration can be measured continuously and over time. Normal values are thought to be 35 to 45 millimeters of mercury, and it displays like this. This is a LifePak 15 display with a EKG, looks like lead 2 in green. You can tell the heart rate is 78, and it's in green, so it's being measured off of the EKG. The pleth is in blue, that spiky waveform in the middle. It's showing 97%, and the bottom in orange, the orange line, is your capnography reading. Currently, it's at 36 millimeters of mercury, and it counts a respiratory rate of 11. Each one of those, with the speed dial wheel at the bottom right, you can spin the speed dial wheel to click on that, press the button, highlight it, change it to whatever view you're looking for. So the end tidal CO2 waveform should be square. Keep in mind that inspiration is the lower part and exhalation is the higher part. Phase 1 is the inspiratory baseline. There should be no carbon dioxide. As you're breathing in room air past the cannula or past the sensor in the endotracheal tube, all of that should be room air. There shouldn't be any kind of excess carbon dioxide associated with that. So that should be close to zero, or at zero. Phase 2 is the initial expiration. That's usually a lot of dead space from the trachea and the large bronchi that starts to rise then quickly as oxygen or as carbon dioxide starts to be exhaled. The top is phase 3. That's considered the alveolar plateau. And the angle between phase 2 and phase 3 is called the alpha angle. So a greater alpha angle makes the waveform look like a shark fin. That's usually interpreted as a sign of bronchoconstriction. The end of phase 3, that is the highest number of exhaled carbon dioxide from the deepest part of the lungs, that's where the end tidal CO2 is actually measured from during that exhalation. As the patient then immediately starts to inhale, that carbon dioxide level should fall precipitously or vertically back down to zero for the phase 1 area here. A good mnemonic for evaluating the orange line is proper quantity, rate, shape, and trend. PQRST, proper. You're confirming the proper endotracheal tube position. The quantity should be 35 to 45. Don't believe it. The rate counts a respiratory rate per patient needs, and the shape should be a square waveform with rounded corners. The trend should remain consistent over time or correcting in the right direction. So these are normal waveforms. All of them have an end tidal CO2 at the end of phase 3 at about 40 millimeters of mercury. They're square-shaped or vaguely square-shaped with a rounded waveform. Keep in mind that the lower part down near zero are the inhalations that's counting your respiratory rate. Here is an example of hyperventilation in comparison to normal. Hyperventilation has a higher respiratory rate. That hyperventilation probably results in a lower pressure of carbon dioxide as the gas is exhaled more rapidly. Hypoventilation has a slower respiratory rate. There's a long phase 3 on this because that's a long period of exhalation. In this case, the end tidal CO2 is also higher than is considered normal. And then this is the increased alpha angle that I was talking about, also called a shark fin. So the blue one on the bottom here is a shark fin waveform, considered to be associated with bronchospasm. As a patient with bronchospasm, like asthma or COPD, exhales, it's more difficult to exhale, and so that rise will not be as precipitous, and it creates more force opening the alpha angle there. It's a more difficult exhalation to get down to the alveolar gas due to air trapping and such. Be careful interpreting that. I've seen patients with shark fin waveforms that have no problem breathing. It's just the way they breathe. I've also seen severe asthmatics without the shark fin waveform, with the vaguely square waveform. There's a study here from, nope, not going to pronounce that name, from the Journal of Emergency Medicine. It says that in patients with severe asthma, the shark fin waveform significantly improved after treatment. However, the magnitude of improvement poorly correlated with peak flow measurements. Peak flow measurements is actually the patient improving, is the actual level of patient comfort. That should be our overall goal, not improving some vague shark fin. Esophageal intubation results in an end tidal CO2 of 0 because air's not being moved past that. And rebreathing and breath stacking is usually a ventilator problem that full exhalation doesn't have time to occur. And so that return to 0 is not always present. This is the problem that I have, and that certain paramedics and certain experts can overinterpret that. There are many ways that I can monitor a patient's metabolic or physiologic status, including pulse ox and lung sounds and plateau pressures and ABGs and the patient's reported subjective comfort. All of those things matter when I'm evaluating patients' respiratory status and whether it's appropriate for their condition. End tidal CO2 is the shiny thing. Be careful following the shiny thing. Use all of the tools and all of your knowledge at your disposal. That is my main thesis, is don't overinterpret what end tidal CO2 can do for you. As a matter of fact, there's a study by Long in the Journal of Emergency Medicine from 2017 that says capnography demonstrates benefit in cardiac arrest, procedural sedation, and mechanically ventilated patients, and in patients with metabolic acidosis. Further study is required in patients with seizure, trauma, respiratory conditions. It should only be used in conjunction with other patient factors in clinical assessment. That last line is the important one, I think. Use it as a tool. You choose which tools to apply and how much to weight the information that you're getting from each of them. Even the idea of end tidal CO2's normal reading being 35 to 45 millimeters of mercury is one that I question. Here's why I question it. PaCO2 is the partial pressure of carbon dioxide in arterial blood. It is measured directly during an ABG. In that case, that number is normal 35 to 45. End tidal CO2 can't have the same number. There has to be a lower number of exhaled carbon dioxide in order for a gradient to exist, for carbon dioxide to move off of the blood and into the lung spaces. What we're actually talking about here is the PaCO2 to end tidal CO2 gradient. It's a representation of dead space, increased gradient, increased distance between the PaCO2 and the end tidal CO2 is a measure of increased dead space. Under normal conditions, according to Sato et al., the normal gradient is 2 to 5 millimeters of mercury. So if a patient has a PaCO2 of 35 millimeters, as low as 30 of end tidal CO2 would be considered normal. 35 is a normal finding for the PaCO2, and a gradient of up to 5 is completely normal as well. Use caution guessing. When I use this, when I transport a ventilated patient or ventilator-dependent patient, I ask for the most recent ABG, preferably one right then and there. I can see on the monitor what the end tidal CO2 is, and I am getting what the PaCO2 is at the same time. And now I know my gradient. That way I don't have to guess about the gradient. Is it 2? Is it 5? Is it more than 5 because this patient has more dead space? It's hard to tell. Deranged physiology has a good discussion. I'm going to leave a link to that. Also a link to the EMS1 article and anything else I'm talking about down in the top pinned comment. Make sure and check that out. But there's a whole lot of literature that you can see here that relates to the end tidal CO2 to PA CO2 gradient. Here's my anecdotal feeling on it. I have put an end tidal CO2 cannula on my face and sat in the back of an ambulance and breathed and watched what's going on as I'm sitting there on my phone and not paying attention to it, not altering my respiratory rate. And I have been in the high 20s, 27, 28, feeling fine, feeling normal. It's not a big deal. What is more important than the number is the patient's condition. Pay attention to that. Go check your own end tidal CO2 and see if it falls within that 35 to 45 millimeter band. I bet it doesn't. This is Angry Bill coming to you from the future. I realized that I didn't describe one of my bigger problems with end tidal CO2 especially well. Picture someone having an end tidal of 31. Sometimes it's even lower. 31, as we have discussed, is not all that abnormal in number. 35 to 45 is normal for PA CO2, and end tidal CO2 has to be lower than that for there to be a differential for the CO2 to diffuse off of the capillary blood into the alveoli to be exhaled. You have a patient with what's considered to be low end tidal CO2. Is that because it's normal? Is that because they're hyperventilating and are hypocapnic and their PA CO2 is also low? Or is it that the patient is actually acidotic and hypercapnic, but has such poor blood flow past the lungs that there's no blood flow to offload CO2 for there to be exhaled CO2 measured? What I've just described is a conundrum between hyperventilation, like a panic attack, and pulmonary embolism. Having a pulmonary embolism means that potentially a large area of your lung doesn't have blood flow to it. It's dead space. Air goes in and it's not seeing capillary blood because it's blocked by the embolus. And so it's just being exhaled without having that diffusion. That's why hypoxia is also common with PE. In any case, it could also be that due to an increased respiratory rate, that the patient's PA CO2 has been blown off, and that's also low. And it's pretty impossible to tell kind of which is going on. So a low number is just a low number. You'll find out. I use it for trending, not necessarily for diagnosis. I think the diagnostic yield of capnography is pretty low, especially in comparison to stuff like EKG. This is future Angry Bill sending you back to past Angry Bill with the glasses and the slideshow. How do I use this? I absolutely always use it during endotracheal intubation to confirm the location of the distal end of my tube. It is even continuous confirmation of the distal end of my tube, and I feel like it's absolutely required. Other methods of confirming tube placement, like visualization passing through the cords, tube fogging, breath sounds, all of those have a lower sensitivity than end tidal CO2 does. Again, it's only a tool. I need to interpret it against the whole clinical picture, but end tidal CO2, I would say, is pretty darn close to an always. It's always required. I use it for monitoring sedation or advanced analgesias, especially at risk populations like pediatrics and the elderly, when I start mixing different kinds of sedatives or when I'm starting to use very strong sedatives. It can help monitor respiratory rate during long transports. Really, though, I should be counting that. It is good to have an apnea alarm, especially in cases where that matters, where that's a potential concern. Waiting for pulse oximetry to fall can take several minutes of apnea. Try it yourself. Again, if you don't believe me, put a pulse ox on yourself and hold your breath. I bet you can hold your breath all the way until you pass out without having that pulse ox significantly fall. End tidal CO2, especially on a LifePak 15 or other monitors, will generate an apnea alarm if there hasn't been a breath taken in 30 seconds. I can use it for trending. As my treatments affect a patient, I can see where both the capnometry and the capnography trends are moving. That's a good thing. It's similar to trending pain scores. And I can estimate the PA CO2 after having an ABG because I already know my end tidal to PA gradient. What I don't use it for is to care about the waveform shape. I think overinterpreting the waveform shape and alpha angles and phase 3 slopes and all of that stuff to the same degree that I can interpret ST segments and T wave shapes, I think is underproven. I don't necessarily worry about capnometry, about the specific number. Remember, I'm looking for trends, not the absolute number. I don't use it for CPR effectiveness all that much. I would rather use my own eyes and my own interpretation of what's going on. And I don't use it to stop CPR during ROSC. I think that that's a potentially dangerous problem. Back to my thesis. Physical exam is at least as important as end-tidal capnography. High index of suspicion and the ability to develop a pertinent list of appropriate differential diagnoses are irreplaceable skills. I can run calls without capnography, but I can't run any call without taking a physical, taking a history, and having a paramedic level thought process. End-tidal CO2 is only a tool. It can only tell you what it sees. It can't tell you if it's important. It can't tell you how to interpret it. You have to use your clinical judgment as well. Outside of the few cases I explained, I can take or leave capnography. It's not the end-all be-all for vital signs. What do you think? Did I convince you? Or am I just an old medic resisting new changes? Let me know down in the comments, please. Speaking of comments, the top pinned comment will have links to deranged physiology and the EMS1 article that set me off. Please check those out. The authors there deserve those clicks. And speaking of deserving, I deserve a like, subscribe, or share. This is Angry Bill for Pre-Hospital Wisdom. Until next time, treat the patient, not just the monitor.